Hospice care is, it is much more than just clinical application, of different measures to control symptoms. Hospice is very much a wraparound approach. And so whenever a patient is enrolled in hospice service, they have immediate access to an interdisciplinary hospice team. And so that team includes registered nurses, it includes nurses' aides that actually come to the home, or to wherever a patient might be, and assist with really lots of different things with daily functional needs, that kind of a thing. Anything that's becoming a problem for patients as they're if they become weak, or if their symptoms are really preventing them from being able to tend to their own basic hygienic needs, or anything in the home that can be difficult, our nurses' aides are able to really step in and assist with that. Very, very quickly after a patient is referred to hospice, a social worker will meet with patients and their families, usually within 24 hours, to really kind of do an assessment and begin to build a very, very much a trust-based relationship with patients and their families, with the goal of just making sure that we're supporting the patient and family in every way we can from a social work end. Hospice typically, and our agency in particular, we employ some wonderful chaplains as well. And so when you think about kind of the multifaceted support that a patient who is facing a terminal disorder requires at home, spiritual support again is something that is just incredibly important. And so we never seek to really get in the way or obstruct a patient's relationship with their own church affiliation, or with spiritual support that they're comfortable with. But we do also have our own chaplains that are just wonderful in helping patients and their families in a difficult situation like that, and very skilled in the kind of support that they can provide. As folks are receiving treatment there at the hospital, really, as things are progressing, if there is at any point we've reached a point where the medical team or the family is inquisitive about kind of what hospice care is about, and what it involves, then we're available to come in and meet with families. We actually are able to help in a number of different ways. We're able to assist with patients that have really made a decision to leave the hospital and receive hospice care in the comfort of their own homes or in long-term care facilities, and we're able to really help facilitate the transport of a patient from the hospital to those areas. We're also able to help with patients who are in very unique situations where they may be declining pretty quickly in the hospital, and would benefit from hospice's direct involvement with their care there in the hospital. The time that makes the most sense for hospice to be considered, at least, and be available for a patient and their family is when a decision has been reached to really step away from aggressive treatment of whatever a patient's primary medical disorder is. And when I say aggressive, I mean treatment with the purposes of curing whatever that disease process is, and really instead shifting the goals of care to a focus on not just provision of optimal comfort. I mean, obviously, when people think about hospice and what we do, folks will think about hospice coming and offering interventions to keep people from having unnecessary pain or respiratory distress or any kind of symptoms that are uncomfortable. But really, when the time is right to really focus on pursuing the highest quality of life for a patient for the time that they have remaining. That's kind of the best way to explain, at least in my mind, the right time, for hospice to get involved in a patient's care. When you think about Medicare and kind of how it defines the appropriate time window for patients and hospice, Medicare typically will look at a diagnosis of anything from 6 months or less. Anything less than 6 months. And so, it's a lot of times people will think, well, hospice is not necessarily appropriate or beneficial to a patient unless, a patient has been given just a very short prognosis of a couple of days or a couple of weeks. And that's not at all the case. There's an opportunity for hospice caregivers to really get, very involved in a patient's, treatment at home or wherever they happen to be. And actually, for many months leading up to the expected point where they will pass away. It's not possible to be referred to early to hospice. Basically, hospice is set up to be very flexible, and that's something that a lot of folks don't necessarily know about hospice, is that when a patient is referred to hospice, of course, we will make it kind of an initial evaluation of how a patient is doing and kind of what their proximity is, what their diagnosis is, and also their prognosis. But whenever a patient is basically enrolled into hospice care, they are certified for 90 days. And so hospice care, when a patient is deemed to be appropriate at the onset of hospice care, then we will reevaluate a patient after 90 days on service. And at that point, if they are continuing, to show just basic signs of continuing along that medical decline continuum, then the patient's recertified for another 90 days. And after those initial 2 periods of 90 days, then the periods will actually kind of decrease to 60 days. But a patient can remain on hospice services for as long as, at each of those review periods, they're basically meeting hospice criteria, showing that, they are declining at least to a degree where they're benefiting from hospice care. Ultimately, if a patient does stabilize and we have clinical evidence of that, then a patient can graduate from hospice. And so a good example of that is in situations where patients are contending with end-stage cardiac disease or some of those more complex progressive illnesses, where their condition can vary and they can have a difficult time and then rally and then have a period of feeling very good. And then, kind of that whole roller coaster effect of some of those very complicated disease processes will cause a patient potentially to graduate from hospice. And at that point, it's not a bad thing. Hospice doesn't take that personally. We basically just kind of step back and remain available to patients if it makes sense for us to get involved again. Whenever I meet with families and patients, prospective hospice patients, that's really the point that I find myself reinforcing often, is the flexible nature of hospice care. A lot of times folks are afraid that if they sign on the line to consent to hospice care, that they're making a legally binding decision that can't be undone at any point, or that doesn't really flex with kind of what their changing medical condition might be. And hospice is there's a lot of flexibility that's built into what we do. And the idea is to have us there when it makes sense to have us there, but then also to allow us to change based on a patient's changing condition as well.